Good afternoon, everyone. My name is David, and I will be today's webinar moderator. Welcome to today's webinar entitled Sexuality After Transplant, presented by Reanne Booker. Reanne Booker has worked in oncology for over 18 years. She began her career as a registered nurse in Edmonton at the Cross Cancer Institute before completing her master's degree in 2007. She has worked as a nurse practitioner since 2005, initially with the Alberta Blood and Marrow Transplant, and later with the surgical oncology programs at the Tom Baker Cancer Center. More recently, Reanne has been working with palliative and end-of-care services team, and in late 2016, she began working with Oncology and Sexuality, Intimacy and Survivorship OASIS program at the Tom Baker Cancer Center. Reanne's clinical and research interests include sexual health and cancer, advanced care planning, symptom management in cancer, and the early integration of palliative care in oncology. Reanne has two daughters, 3.5 years old and 6 years old, who keep her busy and provide a constant source of entertainment. She enjoys running, traveling, and spending time with her family. Before we get started, I'd like to briefly go over the format for this webinar. There will be two parts, a 45-minute presentation segment and a 15-minute question and answer session. All phone lines will be muted during the presentation. You may post written questions during the webinar by using the chat box located to the right of the slides. After the presentation, Reanne will answer all written questions. When there are no further written questions, I will take questions by phone. Should you experience technical difficulties, an operator can be reached by pressing the star key followed by the digit 0 on your telephone keypad. At this time, I'd like to present today's speaker. Reanne, you may begin your presentation.
Great. Thanks very much, David, and thanks to Emma and CBMTG for the invitation. And also thanks to all of you out there who are joining us via phone for this presentation. I'm very pleased to be talking to you today about a topic that is a very important part of quality of life for many patients, but unfortunately is often very underaddressed. Quickly, just to say, I don't have any relevant disclosures. I'm just noticing that the slides aren't advancing here for me on my end. Oh, there we go. As well, I wanted to make a note that this presentation is not intended to be a substitute for medical advice. It's rather just intended for educational purposes only, and to always please consult your physician or your healthcare provider before making any changes to your treatment plan or starting any other new treatments. So I wanted to start today by polling our participants and seeing what your experience has been with this particular topic. So the first question is, I have noted changes in sexual function since transplant. And please note, I can't see who's responding in which way, so it's completely confidential, anonymous. I can't see your particular response. So please, if you would go ahead and select your answer now, that would be wonderful. Okay. So it looks like about 60% of respondents have noticed some changes since transplant, and about 40% haven't noticed any changes in sexual function. The next question is, I'm bothered by changes in sexual function since transplant. So if you answered no to the first question, just skip this question. Okay. And so for this one, yes, about 80% of respondents have indicated that they are bothered by changes in sexual function that they've experienced, and about 20% are not bothered. And I think that's an important point to make, is that even if there are changes that happen, the important component or element of that is it causing bother or distress to the person who's experiencing the changes? And if it is, then we ought to do something about that as the healthcare team. And the final question, my healthcare team is helping me with my sexual health concerns. Okay, so for some this wasn't applicable, but for some they feel that their healthcare team is not helping them with their sexual health concerns. And that's kind of one of the reasons why I wanted to do this webinar today as well, is to provide some information about ways that we can help manage sexual health concerns and just provide you also with some resources. So to get to the next slide here, to just briefly go over the objectives for today, I want to briefly discuss what sexuality is, talk about some of the common changes that might occur in sexuality and sexual function after stem cell or bone marrow transplant, and then talk about some strategies and resources to help manage changes that might arise after transplant with respect to sexuality and sexual function. So what is sexuality? This is quite a busy slide, but I wanted to draw your attention to the bolded section. So sexuality is a central aspect of being human throughout life. And I also want to make the point that sexuality is more than just sexual function. It's not only about sexual function. Certainly that can be one part of it, but it tends to be much more complex than that. So if sex is something that we do, sexuality is something that we are. And that was a definition from a study published a few years back. I think perhaps a more enigmatic question might be, what is sexual satisfaction? What's required for sexual satisfaction? Is it possible to be sexually satisfied without a partner? Is an erection needed? Is ejaculation needed? Can you be satisfied without orgasm? Is emotional or relational intimacy needed? I think these are all very important questions, and I think the answer to this is that sexual satisfaction is something that's very individual, and it really is defined by the person and also the partnership or the dyad that's involved. When it comes to cancer and sexuality, I think it's a very complex situation. Sexuality, as you know, is a very broad concept encompassing aspects of self-image, body image, patterns of affection, social, family, gender roles, and physical and emotional intimacy. There are some factors that influence sexuality that may precede a cancer diagnosis. Some factors or issues may come up upon being diagnosed with cancer, and some may emerge with treatment. And some of these factors may be associated with normal aging, and others may be exclusively related to the cancer or its treatment. We know that sexual function relies on nervous, vascular, and endocrine system function, but it's not just the physical or the body component. The brain is one of the most important sex organs as well. And there are an array of psychological factors that may contribute to altered sexual function and sexuality, including but not limited to body image, self-esteem, mood, depression, anxiety, lack of control, fear, gender role confusion, and many of these factors can be influenced directly or indirectly by the cancer or its treatment. I think it's also relevant to make the point that the impact of cancer on sexuality can vary throughout the stages of the illness trajectory. For example, at time of diagnosis, most people are concerned about what it will take to control or cure the cancer and focus on getting better and surviving. Sexuality may not be at the forefront for most people. However, this is a very important time to ask about fertility preservation, potentially also, if it's important to the patient, what are the sexual side effects of treatment, and how to preserve sexual function and prevent adverse effects on sexual function from happening. Throughout treatment, there can be side effects, obviously, from treatment that can lead to people not feeling particularly interested in sexual activity at the time. There can also be concerns about safe sex practices. So is it safe to be having sex during chemotherapy? Do you need to use condoms and things like that? During recovery and survivorship, this is a time where there's reintegration. People may be experiencing concerns with fear of recurrence. There may be difficulties or concerns about starting new relationships and getting back to a so-called normal or a new normal. And then also during advanced disease and also at end of life, this is a time again where people may not think that sexual function necessarily is that important, but this is a time for many patients and partners where preserving intimacy is extremely important. It may not be about sexual intercourse specifically, but maintaining emotional and physical intimacy can be very, very important for people at this stage of illness as well. And I've included a photo of a hospital bed on this slide just to make the point that Hospitals and hospital beds are not very conducive to maintaining physical intimacy. Hospitals overall, there's not much privacy, and then the beds themselves are typically single beds and difficult for people to snuggle in and such. When it comes to transplant, I think there are some unique challenges. Transplant involves very intense treatments, often with high-dose chemotherapy and often with or without total body irradiation. We do know now that reduced intensity conditioning can lead to perhaps less side effects in some ways, but certainly not minimal. Also with transplant, recovery can be very lengthy, and this can be very difficult. There can be periods of infectious complications and things like that specific to transplant where recovery can be a very prolonged period of time. Also unique to transplant, and specifically for the allogeneic transplant patient population, the potential for graft versus host disease, and specifically involving the vulva, the vagina in women, or the penis or testicles in men. This can have a significant adverse effect on sexual function. The long-term use of medications, as many people are required to be on immunosuppressive medications or anti-infective agents, antivirals, antibiotics and such, can lead to side effects. Some of these medications can have side effects like peripheral neuropathy that can affect sexual function. There's the risk also of late and long-term complications that also may impact sexual function. The immunosuppressed status is also a unique challenge, I think, with the risk of infection being for many quite persistent and prolonged. And then also transplant centers often require patients to travel for treatment, meaning that they may be separated from their significant others, family, friends, etc. during treatment or the recovery phase. There have been some studies that have specifically looked at sexuality after transplant, and this is a review article that was published in 2012, and found 14 studies that looked at the impact of transplant on sexuality. And the authors found that sexual dysfunction is quite common following both autologous and allogeneic stem cell transplantation. They also reported that the recovery of sexual activity generally occurs within the first 2 years post-transplant, but for many survivors, they continue to experience profound sexual dysfunction even as long as 5 to 10 years post-transplant. This work was done by Dr. Karen Cirella at the Fred Hutch Cancer Center in Seattle, and they specifically looked at sexual function before transplant and then followed patients for a period of time after transplant as well, and compared the transplant patients to a population of patients in the general population, healthy controls. And they found that both men and women declined in their average sexual function from before transplant to 6 months after transplant, and women didn't improve from the 6-month post-transplant levels, even as far out as 5 years. Men did improve by about 2 years post-transplant, but they still remained below their respective controls at 5 years post-transplant. So I'll try to get the little arrow here. The dotted lines here, these are the female patients. And so you can see that females started out and their sexual function declined, and then it did improve a little bit, but still stayed well below that of their healthy controls, the little white circle. And for the men, the same thing. Sexual function decreased. It did improve a little bit by 5 years post-transplant, but also remained below that of the healthy controls. The work that we do in our clinic at the Tom Baker Cancer Center, we see patients from every different tumor group, so all different types of cancer diagnoses. And we know that sexual function is adversely affected irrespective of the type of cancer that someone has and the type of treatment that they have. So I think historically and certainly in the literature, there's lots of work that's been done on the breast cancer patient population, gynae cancers and GU cancers, so things like ovarian cancer, cervical cancer, prostate cancer for men, testicular cancer. There's been work done in these areas, but we know now that really any type of treatment that we're providing can have an adverse impact on sexual function. And so for women, we see often reduced libido or desire. We can see changes with arousal, so there can be vulvovaginal symptoms such as vaginal dryness and irritation. There can be difficulties with orgasm. painful intercourse, ovarian failure, and premature menopause in some women. And there can be some specific disease and treatment concerns that arise. So in the transplant population, vulvovaginal graft versus host disease, if there's surgery that's affecting the female sex organs, and typically that would be, again, in breast cancer or the gynae cancer patient group, there can be adverse effects on sexual function following that. And altered fertility is also quite relevant. And then an array of psychosocial concerns as well that may arise. For men, we see also similar changes, and we see changes with respect to decreased libido, difficulties with erections, difficulties with ejaculation, again, orgasm difficulties, changes in hormone function as well. For the men, potential testicular or penile graft versus host disease and altered fertility. These are all concerns that can happen after transplant as well as after different types of treatment for cancer. And also in the male population, significant concerns can arise with body image and self-esteem and different psychosocial issues, relationship difficulties as well. I think the number one, or the kind of the most common concerns we see in the male population tend to be around decreased libido and difficulties with erections. And in the females, we're tending to see difficulties with vulvovaginal symptoms, so dryness and painful intercourse and that kind of thing. So to delve a little bit more in depth into some of these specific concerns, we see in both men and women changes in libido or desire. And this can happen with any of the treatment modalities for cancer. It's also something that can happen as we age, and there are a number of other reasons that can cause changes in libido and desire. I think this, historically we used to think of the sexual response cycle as being somewhat linear, so that you needed to have desire first, and then after that you'd have arousal, and then orgasm, and then a period of resolution perhaps. And there are some variants on that cycle as depicted in this picture on the left. However, we know now that this notion of spontaneous desire is perhaps not what we once thought. So we know that desire may arise later in the cycle after arousal, for example, and that it's not necessarily a linear experience. So if we look at the model on the right, it's more complex, it's circular. You can see that it's not necessarily a simple linear experience. And in Rosemary Besson and her group out of UBC, they've really looked at this, and in particular in the context of female sexual satisfaction and female sexual function. And they know that sexual satisfaction and not orgasm appears to be the focus in some women. And so if a woman begins a sexual response experience from a point of relative sexual neutrality, so meaning there isn't that spontaneous desire, but with the goal of emotional intimacy and being close to her partner, she might end up actually being receptive to sexual stimuli, and that arousal and desire might actually come later in that sexual response cycle. And so it's just kind of letting go of this notion of needing to have spontaneous desire to be present in order to participate in an enjoyable or satisfying sexual encounter. So as I mentioned, for women we do see a lot of difficulties coming up with vulvovaginal symptoms, and quite often these are associated with menopause, whether it's natural or treatment-induced. We know that many of the modalities of treatment for cancer can cause treatment-induced menopause, and this abrupt loss of estrogen can lead to severe symptoms, often worse than what occurs with natural menopause. For some, this menopause may be permanent, and for others it might just be temporary. We know that the hot flushes and vasomotor symptoms and night sweats and things like that tend to abate over time, but that the urogenital changes, the changes in the vulva and the vagina, do not get better over time. In fact, they can get quite bad. And so we see, as I mentioned, difficulties with dryness, decreased moisture and elasticity. We can see where the labia minora, the inner lips of the vulva, actually can get resorbed, and it can actually kind of disappear. We can see changes with severe stenosis of the vagina, difficulty with lubrication with sexual activity, which can lead to painful intercourse and bleeding after intercourse, and just a whole array of different symptoms that affect the vulva and vagina. We can also see urinary symptoms, recurrent urinary tract infections as the pH of the vagina becomes more basic and the microorganisms that reside in the vagina change. Postmenopausally, a lot of women are prone to recurrent urinary tract infections. So a whole conglomerate of different symptoms and issues can come up after menopause. And we know from the literature that young survivors rate premature menopause and sexual dysfunction as one of the most distressing aspects of their cancer experience. Just to make the point that vulvovaginal graft versus host disease, we do see some similar types of changes in the vulva and vagina with redness and irritation and those kinds of symptoms. And there's often kind of an overlap with the changes that arise from hypoestrogenism. So it can be a little bit difficult to kind of sort out what's happening, but in our clinic we are seeing and treating both loss of estrogen as well as vulvovaginal graft versus host disease. So for the men, as I mentioned, we do see a lot of difficulties with erectile function where there can be difficulty achieving erections, difficulty maintaining erections, and insufficient firmness or rigidity of erections. And we know that men require firmer erections for anal intercourse than with vaginal intercourse. It's approximately 30% firmer than what is required for vaginal intercourse. And we also know with erectile difficulties that this can happen with normal aging, even in the absence of a cancer diagnosis. And we know that there are a number of different medical conditions and medications that can also influence erectile function. I think the good news is, and not everyone knows this, is that you can still have ejaculation and orgasm even without an erection. The reasons for erectile difficulties can often be very multifactorial, and we know that erectile dysfunction can happen if there are any problems with nerve function, blood flow, hormone function. We know more recently that there can be concerns, anatomic concerns, where there's loss of compliance with the penile sinusoids associated with increased deposition of collagen and decreased elastic fibers, and that can happen with diabetes, high cholesterol, vascular disease, penile injury, and I would question if this could be something that might arise in the context of penile graft versus host disease. We don't have a lot of literature on penile graft versus host disease, but this potentially could be a contributing factor to erectile dysfunction. And we also know that there can be psychogenic components too. So the impact of a cancer diagnosis on erectile function can be very profound, and there can certainly be a lot of difficulties with that after treatment. And so changes in ejaculation, much of the work and what we know about changes in ejaculation in the literature is based upon the experience after treatment for prostate cancer. Certainly in the BMT and stem cell transplant patient population, we do occasionally see men experiencing pain with ejaculation, and that may be caused by irritation of the urethra from radiation. We sometimes see aching in the testicles with ejaculation as well, and that tends to subside over time. Again, most of these changes and that with ejaculation have been based upon prostate cancer, and less is known about changes in ejaculation after transplant. Changes in orgasm, we know that this can happen for both men and women, where we can sometimes see decreased intensity, increased intensity, or no change. We can see sometimes that it takes longer to achieve orgasm, and this might be due to neuropathy or altered hormones, discomfort or pain with sexual activity, or also, again, the power there of the brain and the mind, and that can have a significant impact as well. We see sometimes a muted orgasmic response where a colleague and friend of mine, Michael Critchman, a gynecologist in the U.S. and California, said that for some women after menopause or after treatment for certain types of cancer, he's heard them report that their orgasms are different, so they might be a bit muted. He said, whereas there used to be a thunderclap, now it's just the pitter-patter of rain, so kind of a diminished orgasmic response. In our clinic, we have seen that patients have had changes with orgasmic response to some degree, but many people still retain their ability to have an orgasm. It might take longer, or it might require different types of stimulation, such as oral, manual, or vibrator use, and that kind of thing. but we do still see that many retain their ability to have orgasms. It just might be somewhat different than prior to treatment. And again, to make the point that you can still, for men, you can still have an orgasm even in the absence of an erection. And I won't get into this too much today, but fertility also is a huge area of concern for patients undergoing treatment for cancer and certainly for transplant. We know that transplant can have a profoundly negative impact on fertility. And in women, ovarian failure is very common in women who are they say older. I myself am in this category now, but over 35. So if you're over 35 and you're getting certain types of chemotherapy, so in particular alkylating agents, drugs like busulfan, cyclophosphamide, ifosfamide, and those kinds of medications, that increases the risk of infertility. Total body irradiation also increases the risk for infertility. For women, there are a number of different options for fertility preservation. The most common one right now that is recommended is in vitro fertilization, and it's got about a 20 to 40% success rate for pregnancy. There is a window of time that's needed, so sometimes that's not practical, that you can't delay treatment while you're pursuing in vitro fertilization, and it can also be quite costly and is not covered by most health plans in the country. The most recent numbers I've gotten from our local fertility program here is it costs about $5,000 to $8,000 per cycle and about 350 years per storage per year for storage fees for the embryos. So it can be quite costly. For men, we know that many men may regain their ability to produce sperm. That can take up to 2 years post-transplant, but we also do advise men to consider sperm banking prior to transplant just to preserve fertility. Following transplant, you can have semen analysis done to check the quantity and quality of sperm, and again, also looking at sperm banking prior to transplant, and even should be done prior to any chemo, ideally. There's costs associated with that as well. Usually here in Alberta, it's about $400 for the initial assessment and deposit, and then deposit of semen, and then about $200 per year thereafter for storage fees. There are programs in the country that can help with fertility preservation costs, and so that's something that we advise people to consider because it can be quite costly. And in moving on now to body image, we know that there are many changes that can occur with treatment that may adversely impact body image. In the transplant world, for sure, we see difficulties with hair loss, weight gain, with prednisone especially, weight loss for some. There can be profound skin changes after radiation or busulfan. There can be bruising, petechiae, graft versus host disease can cause some changes in skin as well. There can be scars related to ports and different things like that, and these changes can be very profound. A study we did a few years back, one of the participants had said to me, I quote him with his permission, he said, "I remember the first time I looked in the mirror, when I got up to go to the bathroom, and I literally fell to my knees sobbing because I didn't recognize the person that I saw. See, I'm trying to fight tears off now, talking about it. I've mourned the loss of who I was. I was stronger physically. Now I'm, I'd say, 90% of what I used to be. I've got a much bigger heart. Some say it's the girl blood that makes me cry so easily." So he had a female donor. And another person in our study said, "You might not feel that good because you don't have any hair or eyebrows and you have tubes sticking out of you. So, there's all that kind of stuff. But you know what? If your partner really loves you, you see past it. My husband was like, it's like you have a Brazilian." He's like, right on, because she lost hair and she lost her hair everywhere. So different impacts, though, for sure, of treatment on body image. And there are programs at many cancer centers that can help with body image, and also certainly programs like psychosocial oncology that can help. Relationship changes, I think this is an area that can be very difficult for existing relationships, either new relationships or long-term relationships. How will the cancer change the relationship? There's difficulties with caregiving and role responsibilities and role reversals and things like that. And then there can be profound difficulties when starting new relationships. when to disclose the cancer history and when to share that. It can make the dating landscape very difficult. There's one great website, and they quoted a young cancer survivor, and she said that she considered her cancer history her douchebag filter, and when she'd bring up this history and somebody would react badly to it, she would say that that was her douchebag filter, and she was done with that person and moving on. But it's very difficult, and it can be challenging to navigate that for sure. There are a number of different resources out there, some excellent resources online, and I've posted some here on this slide, and I've got some also at the end of the presentation. We know the impact of cancer treatment on partners can also be very significant, and this is an area that has garnered very little attention in the literature. We know partners might have a fear of initiating sexual activity because they might be worried about causing their partner pain. Partners themselves might feel unwanted or unattractive, and they might feel a sense of rejection as they're not aware of the impact of treatment on the patient's sexuality. There can be a change in role where the caregiver role may change how the person sees the other in a sexual way, and the change in role may also mean that the partner has to now take on a dominant role in sexual activity, and that might be new or different. There may be a disconnect or distance in anticipation of potential impending loss or fear of loss. The partner may look differently at the patient due to physical or behavioral changes, sometimes because of treatments or meds and things like that. And partners may also have their own sexual health concerns as well. So all of this can be very complicated and difficult to navigate for sure. But the good news is, I think, is we've got a lot of interventions that can help. In our clinic, we've taken a very biopsychosocial approach to how to manage these concerns. We know that it's not just only about the body. The mind has a very significant role as well, and we're very lucky in our clinic that we've got somebody who addresses kind of the physical and clinical concerns, and we've also then got psychologists in our clinic that can help with many of the psychosocial issues as well. So things to think about when thinking about different interventions. We want to know that, this is a loss. This change in sexuality and sexual function, it may not ever return to baseline, and that's a loss. And it's okay, and it's actually very important to grieve this loss. We want people to think about considering sexual activity despite low libido, and that we know that sexual activity doesn't have to be preceded by spontaneous sexual desire. And in fact, spontaneous sexual desire may not be a reality for many people. Engaging in sexual play is arousal, and desire can then follow, so that's a recommendation that we have. Promoting flexibility and trying to take a broad outlook on sexual activities with different positions and different activities and things like that. Thinking outside the box and realizing that it's not just about intercourse, and realizing also that arousal and orgasm can still happen in the absence of erections. These are all some recommendations. Specific interventions, we have a great team at our cancer center that can help with communication and partner and person awareness. We have a number of different non-invasive assistive devices and such, and I'll get into that in just a minute here. And then there are some specific medical interventions and referrals that can also be helpful. With communication, we recommend that patients, as much as they can, speak about these concerns with their partner. Patients might wait for their partner to initiate activity or to bring this up, and partners might wait for the patient to bring this up or to initiate sexual activity. And as a result, this might be something that just kind of falls by the wayside and just doesn't get addressed. We know that certainly happens with healthcare providers, is that we often wait for patients to bring the topic up, and they often wait for us to bring it up, and as such, it often goes undiscussed, under-addressed, and just not dealt with. Take it slow and really try to keep talking to each other. And this, if you're in a relationship where communication has not been particularly strong, this can be very challenging. But as much as you can, seek help for this if it's something that's within your comfort zone. And there may be complete avoidance of physical intimacy, and there's concern sometimes too that one partner doesn't want to start something that he or she cannot finish. So again, there can be a complete avoidance of sexual activity. So speaking to your partner can really help to clarify what's going on for you. Improving intimacy, I think, is really important as well. And I think, again, we like to encourage people to take intercourse off the table, that intercourse may not be the be-all, end-all, and that we want to find ways to help preserve and protect intimacy, emotional intimacy, sensual and sexual and physical intimacy as well, but not just sexual intercourse. We talk about sensual activities and different things couples can do together, partners can do together that don't involve penetrative intercourse. So there's something called very erotic non-insertive sex, different types of sensual touching, and things like that. Sensate focus is a special exercise that our psychologists can help guide patients and their partners to do. And it's meant to enhance intimacy in the relationship and alleviate anxiety related to intercourse. And intercourse actually is not even part of it towards the end of, it's about a 6-week program, and it starts just with touching and trying to figure out what feels good and what doesn't, and communicating with partners. Improving desire, we know that this can be a significant concern for both men and women after cancer treatment. And just being, again, aware of that responsive desire versus spontaneous desire, and that once you start cuddling or you're laying next to your partner or dancing or physically touching, that responsive desire might come even if that spontaneous desire was absent. We've got a great team, again, of psychologists that can help with mindfulness-based meditation and different strategies through counseling that can also be very helpful. I think also if we can find ways to manage other concerns like pain with intercourse, erectile concerns, ejaculatory concerns, and things like that, that can also go a long way in terms of improving desire. So in terms of improving erectile function, we know that there are lots of different strategies. There are medications and there are different assistive devices and such. And again, counseling and psychotherapy can be very helpful. Looking at reframing sexual practices as well. So maybe it's changing from intercourse as the goal to oral or manual stimulation and things like that. These are some examples of external aids for erectile function. So this is an external penile prosthesis or strap-on dildo. This one here is a penile sleeve. This is a particular brand or device called the Elator, and it supports the penis to help keep it in an erect position. The final one here is a vacuum erection device, and it helps to pull blood into the penis. Medications, we do often use medications to help with erectile function in our clinic, and they help by improving blood flow to the penis. They're not helpful in all cases of erectile dysfunction. It really depends on the cause. For example, if the etiology or the reason for the erectile dysfunction is neurogenic, patients may not really find these medications to be that helpful. Or similarly, if we need to look at replacing testosterone, we might have to do that first before these drugs will have much of an effect. There are 3 main different drugs in this class, sildenafil or Viagra, vardenafil or Levitra, and tadalafil or Cialis, and they all work very similarly. The biggest difference is that Cialis has a longer half-life, and there is a 5 milligram daily dosing option as well for Cialis, which can allow more spontaneity and that kind of thing. These medications do not cause indefinite erection, and they do require sexual stimulation before they work. And it's really important to also note that if prolonged erections occur, that is lasting longer than 4 hours, that's a medical emergency, and the patient should seek medical attention at the nearest emergency room. And also, we advise patients not to use nitrates, such as nitroglycerin, because that can cause a really low blood pressure to occur when they're using these drugs concurrently. So other options we have in our clinic also done some intracavernosal injection therapy, and this is where a small needle is used at the side of the penile shaft, and this it can be very, very effective for patients who have neurogenic or nerve dysfunction-related erectile dysfunction. We don't typically use this as first-line therapy. We'll try other options first, but it does have a very good rate of success for patients, in particularly patients who have neurogenic erectile dysfunction. The transurethral therapy is where a little pellet is put into the urethra, and it's absorbed from the urethra. The medication is absorbed from the urethra and transported through the erectile tissue, and that can be also effective in some cases. And We have vacuum erection devices, as I mentioned already, what's also known as penile pumps, and their efficacy is about 90%. You really do need to get a good medical grade quality device for it to be effective. Inflatable implants, these can be a 2 or 3 piece design, where the 3-piece implants have a fluid-filled reservoir that's placed in the abdomen, and there's a little pump that can pump up, causes a transfer of fluid from the reservoir into the cylinders in the penis, or the 2-piece ones. The pump is in the scrotum, and you can pump it up and cause the fluid transfer into the penis, and then when you're ready for the erection to be done, there's a deflate kind of valve, and the fluid goes back into the reservoir. And semi-rigid or malleable rods can also be implanted. They're kind of bendable rods, usually constructed out of stainless steel wires or articulating plastic discs covered with silicone. And the rods can be bent upward to have sex, and then pointed down again to conceal the device when erections are not wanted. And those are quite effective as well. For females, managing vulvovaginal symptoms is, we've got lots of different options for this. And so we like to encourage people to, again, just like the men, consider a number of these different options, and also counseling or psychotherapy is very important. I want to make the point that we do recommend moisturizer use, vaginal moisturizer use for women, much like you moisturize your face. This is something that should be done regularly, so at least 2 to 3 times per week. And moisturizers are not intended to be used for sexual activity. They're meant to be used more to hydrate the vaginal tissues and to improve vaginal pH and keep those tissues healthy. It's best to use them before bed because once you've inserted them, if you stand up and are going about your day-to-day business during the day, gravity can cause these moisturizers to kind of leak out. We do recommend that women rub these moisturizers on their vulvar tissues and the introitus, or the opening of the vagina, as well, because those are also areas of the tissues that can be quite dry and irritated after treatment and after loss of estrogen. Lubricants, by contrast, are meant to be used for sexual activity or pelvic exams, and you want to use these quite liberally during sexual activity, and apply them really to anything that is going into the vagina, and also and also around the vulvar tissues and vagina itself. And their intention is to minimize friction really during sexual activity and to help manage that discomfort. For some women, they report that they feel quite dry all the time, and they can really have an awareness of this. It's quite uncomfortable during the day, riding bikes and things like that. And so you can use lubricants to help minimize that symptom as well, but the lubricants are not going to treat that. They're just going to manage the symptom. It's the moisturizers that are really going to be helping in terms of improving the health of the vaginal tissues. Lots of different moisturizers out there. It's kind of just like you would use for your face or your skin. You sometimes just need to try these things and see what works best. We advise people to avoid using things with particular irritants. Some people react to propylene glycol, which is a preservative in many of these products. So check the ingredients list if you can. Glycerin also and different sugars can cause yeast infections for some women. So again, look for those ingredients. Similarly with lubricants, these can contain different additives that can be irritating to the tissues. So again, avoiding fragrances, flavorings, heating and cooling agents and things like that, because it can be quite irritating. I'm aware of the time here, and I'm going to speed it up and hurry up. You can also use natural products like vitamin E oil and coconut oil to help to use as moisturizers and also as lubricants. Vaginal dilation may help with patients who have had pelvic radiation, surgery, vulvovaginal changes after menopause, chemo, etc. We recommend that these are used regularly, and they can help to kind of gently stretch the vaginal walls and tissue to help make, with the end goal, I guess, of being to help make vaginal penetration or speculum exams more comfortable. There's instructions on how to use a vaginal dilator available online, and also in a brochure we've got available at our cancer center in Calgary. Also to say that you can use a vibrator to dilate as well. You can use this with or without the vibrating function on. You'd want to find something that's relatively tapered at the end and not too big, so just to ease the insertion. I wanted to mention also about the dilator set, the dilators in the previous slides. Some of them come available as sets, and so you start with a smaller size, and you can increase gradually to the size that you can tolerate. And that would be a limitation potentially with vibrators, is they just usually come in one size. So you'd have to get a size that's comfortable and gradually increase the size. Vibrators can also be used for sexual activity and stimulation with or without a partner, and there are many different models and types available. We often will recommend to our female patients and also our male patients who've undergone certain types of treatments to consider seeing a pelvic floor physiotherapist. We know that there can be pelvic floor dysfunction that can happen after certain types of treatments and after loss of estrogen from menopause. I would also question potentially after graft versus host disease, where we can sometimes see the pelvic floor muscles becoming very hypertonic or tight, and this can result in painful intercourse. And we've heard patients say that they feel like their partner is hitting a wall, or the partner might say, feels like I'm hitting a wall, and that often is a consequence of pelvic floor hypertonicity. So pelvic floor physiotherapists can be very helpful in managing this. Hormone replacement therapy, we advise people to talk about this with their oncologist, their family doc, their gynecologist, their endocrinologist. It's really an individual decision where the risks need to be carefully weighed with the benefits. But we do know that altered hormone function after transplant is very common. And in women, this can lead to vaginal changes and low libido. And the use of systemic hormone replacement therapy for premature ovarian failure should really be individualized based on the patient age, severity of their symptoms, menopausal symptoms, bone density, risk of breast cancer, etc. In men, we know that hypogonadism is very common also after transplant, and impaired spermatogenesis, erectile dysfunction, low testosterone, and low libido can occur in male patients. We do look at replacing testosterone for some patients, although we know that sometimes this improves dramatically by up to about 2 years post-transplant. And as with hormone replacement therapy in women, there can be some risks. So again, this is a very individualized decision-making process. For women, we do talk also about local estrogen therapy, and we suggest using the lowest dose for the shortest duration. But we do know that local topical estrogen can profoundly improve vulvovaginal symptoms. It does not treat vasomotor symptoms or bone density, osteoporosis issues. We've got different varieties of local topical estrogen available. Vagifem is one option. It's a tablet. It's the picture on the bottom of the screen in the blue applicator. It tends to only treat the upper part of the vagina, the upper 2/3, and we recommend that women do rub some of the creams and that on the opening of the vagina and the vulvar tissues as well, because those tissues can also become quite irritated and sore. We do know that there can be systemic absorption, though it tends to be quite minimal, and it tends to be most significant during the first few weeks of therapy when the vaginal tissues are very thin. But for people for whom estrogens are contraindicated, this would be something that would need to be considered. Testosterone replacement for the men, again, can help with bone health, energy, and libido, and should be discussed with healthcare providers. We do know that men can have a low testosterone after transplant, but for many this does recur by up to 2 years post-transplant. There are many herbal products or natural products out there, and we just advise caution with these because sometimes there can be constituents in them that might interact with your treatments or other medications you're taking. And also to make the point that at the World Meeting on Sexual Medicine in Chicago in 2012, there was a study presented where researchers tested herbal and natural performance enhancement supplements, the so-called gas station Viagras and such. And they found that a lot of them did actually contain an active pharmacologic ingredient. Some of them were in fact overpotent. Some of them contained actually all three, tadalafil, sildenafil, and Levitra, sorry, its generic name escapes me at the moment. There were labeling inadequacies as well with no expiration date or lot numbers included, and other analyses have found that there were fillers used such as brick dust, ink toner, and such. I am almost done here. Safer sex, I just wanted to make the point that there are no great or good quality research studies done to examine how much chemo remains in body fluids, such as oral, vaginal, penile, secretions, and semen after treatment. So part of the difficulty in studying this is that so many different drugs are used to treat the various types of cancer, and often we use these drugs in combination. It would be very difficult to figure out how each drug is being metabolized, and each person metabolizes or breaks these drugs down differently anyway. But with that being said, we know that the majority of chemo is out of one's system, usually within a few days of having received the medication. It's expected that the amount of chemo that remains behind in oral, vaginal, penile secretions, and semen is very, very small, and the significance of partner exposure to secretions containing what we think would be very minute amounts of chemo is unknown, really, but the risk of harm is thought to be quite low. However, we do recommend, and most cancer centers recommend, that patients wait for at least 72 hours before engaging in intercourse or giving or receiving oral sex without a barrier method of protection, so that's condoms or dental dams, just to prevent partners from exposure to chemo that may be present in bodily secretions. We also advise that when platelets are really low, so usually less than 50, or white blood count and neutrophils are low, we advise patients to be cautious because there would be potential for increased risk of bleeding when platelets are low, and increased risk of infection when white blood cell counts and neutrophils are low. So the take-home messages from this talk, really it's common for changes in sexuality to occur after transplant for both the patient and the partner. What matters really is how the changes affect the individual person and the partner, if the patient has a partner. We know that the early identification of graft versus host disease is key, particularly for women for vulvovaginal changes. Regular assessment of the vaginal tissues is really critical, and we are advising women to actually look down below or have a partner look down below regularly after transplant to make sure that those changes aren't happening. We've seen people a few years out from transplant who haven't been partnered or haven't had sexual activity since transplant, who then go to try and have either intercourse or a pap test, only to find that the vulvovaginal tissues have become so significantly altered that it's difficult to get a speculum in or difficult to get a finger or a penis or anything in. And so early identification is really key. We know that there are lots of different things we can do to help improve sexual function after transplant. And really we want people to let go of the idea about a normal sex life or a perfect relationship, the right amount of desire, etc. Talk to your healthcare provider to find out what options might be best for you. If something isn't working, think about trying something else. Don't be discouraged. It may need more time to kick in, whatever it is, or you might need to try something else or a combination of a few things. And things might be different, but that doesn't mean that you cannot still have a good quality, satisfying sexual relationship. It just might look different than it did before treatment. And just really keep talking to your partner, your healthcare provider, and don't give up. We invite you to contact us and Tom Baker if you, at the Cancer Center if you've got questions, or if we can send you any resources. These slides do provide some information on some resources, and I invite you to look at those websites. Again, too, for products and vibrators, dilators, and lubricants and things like that, there's a number of websites here that are quite helpful. And I'll just end here with this slide that says, no, I said, I've got acute angina. And David, I'll stop here now, and happy to take a few questions. I know we started a couple minutes late, so hopefully I won't bother anybody by staying a few minutes late here to answer questions if they've got some. Thanks very much.
And that concludes the presentation segment of the webinar. We will now begin the Q&A session by addressing questions submitted via the chat box. We will give participants a minute or two to submit their questions. After we have answered these, we will take questions by phone. Please bear in mind that all questions will be broadcast to the entire webinar. Speakers will not be able to comment on the care of specific patients. Please refrain. Since we do have no questions at this time, once again, we'd like to thank you for joining today's webinar presented by CBMTG. We would like to alert you that a webinar evaluation will be sent to you via email following this presentation. Your feedback is important to us, and we hope you will complete the webinar evaluation. Please check cbmtg.org for information on upcoming webinars. You may now disconnect.